Thank you, Malika, and thank you, Hyderabad Ophthalmic Society, for this kind opportunity. My case is a 47-year-old man who comes to us decreased vision in the left eye for 1 year. The vision has been actually progressing and painless, and he also has metamorphopsia. He says that almost 2 years ago, he had some episodes of foreign body sensation and redness. He has shown at Delhi, actually, from where he came. He has been managed on topicals, oral steroids, not responding, now biologics being considered when he came for a second opinion. His best corrected visual acuity in the left eye was 660. Rest was kind of normal, except when we come to slit lamp. Slit lamp showed 1 plus cells, 1 plus flare. There was some cataract, but no posterior synecdoche. Vitreous showed 3 plus cells, and there were vitreous membranes. This was the right eye, which was normal, and this was the left eye. So you can see there was a vitreous haze. He was intermediate uveitis. So we kind of did what we do. We did the fluorescein, right eye completely normal, and the left eye showed some leakage from the vessels that can be expected in intermediate uveitis. There was some leakage from the capillaries also, and my fellow thought it could be Behçet's. There was no oral or genital ulcers. And there was this huge cystoid macular edema, which you can appreciate during the late phase of angiogram. We did the OCT. This is the frame passing through the fovea. You can see there is a lot of macular edema with subfoveal serous detachment, cystic spaces, and everything. So what did we miss, or what did the uveitis experts was previous to us miss? Because the patient has been going on for 1.5 years, here and there, and on biologics, going to be on biologics. So the investigations are something that he was carrying with him. I'm just mentioning the relevant one because he was carrying this huge file with him that had MRI and everything. The Montius is spelled wrong, sorry. But it was normal, and syphilis was normal, chest was normal, ACE was okay. So, there was nothing positive in the investigations. So what did we miss? If you see carefully, there are few linear, I would call it a thing right now, which are in the nasal half of the retina. About 2 or 3 of them we could see. We did not know what it was, but we could see that there were some linear shadows in the nasal half of the retina. So we go back to the retrospective history. So what he has been saying that he has on and off redness and irritation in the eye. Now he comes with the history. And believe me, these uveitis patients, you really need to sit with them, talk to them if you really want to get history. He said he had a trauma to left eye with caterpillar while he was riding a motorcycle 4 years ago. And the hair was on the cornea and conjunctiva of the left eye, which was removed under the microscope. He is a senior bureaucrat. So at that time, he was posted somewhere in Rajasthan. So he had those records where this hair was removed. And subsequently, he developed intermediate uveitis 2 years later, but I believe nobody correlated the two things. And that's how he ended up in a situation like this. So our final diagnosis now comes down to left eye caterpillar hair induced intermediate uveitis. We did a thorough UBM 360 degree to see if there was any hair in the ciliary body before we planned any surgical intervention, and there was none. So the treatment changes from steroids, from immunosuppression, from biologics, and blah, blah, to simple vitrectomy. And since he also had cataract, we did a combined surgery. So this is the surgery, nothing unusual. So you can see the phaco has already been done. So we go ahead, we do the vitreous, and of course, you know, we love to do flow cytos and all for many other reasons. So we took a good sample, but honestly, this was more of a therapeutic where we just had to remove the hair and it did not have any diagnostic challenge. So the hair, there were two hair, I think. As you can see, one of it was in the vitreous, which was just cut with the help of the cutter. After the scleral indentation in the periphery, so it came out. There was another one which was lodged here, and this was kind of, I just teased it later with the forceps, removed it from the underlying vitreous where it was kind of embedded here. I think maybe, yeah. So I do have the video. So it was just teased off, taken out into the vitreous, yeah. And you can see, then just cut it. There was no attempt made to remove it in toto because there was no diagnostic dilemma, so no point in extending the sections and doing histopathology or anything. So that's the moral of the story, that sometimes we get caught on with the phenotype that the patient is presenting and we don't even pay attention. So of course, we keep on doing all this crazy stuff, but there was nothing except it show on flow cytometry. There were few B cells mature. So when we talk of caterpillar hair-induced inflammation, it has 5 types. Type 1 is an acute anaphylactoid reaction, which starts immediately and lasts few days with chemosis and inflammation, mostly in the conjunctiva. It can become type 2, which is chronic mechanical keratoconjunctivitis, because the hair gets lodged either in the bulbar or palpebral conjunctiva and may have corneal abrasions. So I guess when he got his hair removed, it was type 1. Type 3 is formation of a grayish yellow granulomatous nodule in the conjunctiva, because hair might be subconjunctival or intracorneal. And type 4 is iritis, which is secondary to hair penetration into the anterior segment. And these patients actually come with very severe iritis, nodules, and hypopyon. And this is something we call ophthalmia nodosum because it comes with very severe inflammation. Type 5 is something which is not usual to see and which our case had as vitreoretinal involvement after hair penetration into the posterior segment. So involvement is there, just 10 to 20%. Hair migrates to the posterior segment through anterior chamber or sclera. So it may take months or year to cause vitreitis or even endophthalmitis. And you have to remove this setae because these are the causative inflammation. So the patient, I did keep him on steroids for some time just to give a cover. But within 6 weeks of the vitrectomy, he was off all medications, and he came back after 4 months. Now he could not come due to COVID, but his vision, he says, has significantly improved to 6/9. And he's a happy guy because he's off all the toxic drugs. So sometimes it's important not to be kind of get carried away by intermediate uveitis simply because you are seeing a particular phenotype. And we keep on, doing this wide field fluorescein, wide field ICG. So you have different toys and you like to order OCTs. You see OCT or macular edema, inject Ozurdex, inject, but that's not all about it. 2 important things are talking to the patient and clinical examination. I think that is where we are lacking in our teaching, in our training, because it's all become so technology driven. And that is why cases like these keep on hopping from place to place. Thank you very much.